So if you guys have been impressed by the first couple of speakers, you're about to be wowed by the next speaker. A good friend of mine, Tarlan Hedayati. She's one of the associate program directors up at Cook County. I was really fortunate enough to be invited up there to do grand rounds, and they just have an amazing program up there. She's coming all the way down, obviously, from Chicago, Illinois, and her Twitter handle is Chi-Town Girl.
You got it.
G-U-R-L.
G-U-R-L, yes.
All right, take it away, Tarlan. Thank you so much.
Thank you. Thanks for having me. And I think we're about an hour away from lunch. Do you guys want to just stand up for 30 seconds? I know you've been sitting for a while. Do you want to just stand and just shake your arms and legs out a little bit? Let's do it. We'll do it all together. Oh, I know, right? Get the blood flowing again. We're increasing our cerebral perfusion again. All right, cool. Here we go. So we're going to be talking a little bit about STEMI equivalents and high-risk ECGs that you should be aware of and that you might want to consider activating the cath lab or at least getting your interventionalists involved sooner than later. No financial disclosures. So when we talk about these high-risk ECGs, we're talking about pattern recognition. And I used to love these standardized tests that they used to give us in like 3rd and 4th grade, where they would put this problem up and you had to figure out what the next object, what the next shape was going to be. And so if I ask you, what's the next shape in this pattern, what's the next shape? Square, yeah. So the next one's going to be a square. And so your eyes kind of take a look at the various objects and you figure out what the next thing is going to be. It's about anticipation. It's recognizing the pattern. And so it's the exact same philosophy when we're looking at ECGs. And we're taught how to interpret ECGs. We look at the rate, we look at the rhythm, we look at the axis, we look at the intervals, the ST segments, and the T waves. And we go through that systematically. And then the next thing I want you to do by the end of this lecture is to be able to take it to the next level and go through the patterns that could determine high-risk ECGs that need the cath lab besides STEMI. So we all know what a STEMI is, the hard definition. So any new ST elevation at the J point, 2 or more contiguous leads over 1 millimeter. Now we make some accommodations for V2, but for the most part, this is what we're talking about. ST elevation more than 1 millimeter in 2 or more contiguous leads, or ST depression in V1 through V3. That's a posterior MI. So that is the only non-ST elevation. So it's an ST depression that we treat like an ST elevation because it's a posterior infarct. Now, when you look at the ECG, you want to think about the ECG in terms of families. So there's certain leads that go together, and that's what we mean by contiguous leads. When we're looking for ST elevations in 2 or more contiguous leads, it's based on these families. So this is an ECG of a patient that we had at our institution. And so what's the first thing you see here? The thing that jumps out. Who sees the STEMI? Yeah, so there's huge ST elevations in those inferior leads. Is it more than 1? Yeah, it's more than 1. And so those are the 2 or more contiguous leads. Those are all in the same family. So let's break down this EKG. So 1 AVL V5, V6 is the lateral family. So you want to think of those leads all together. When you see an abnormality in 1, take a look at AVL, take a look at V5 and V6. If you see more than 1 lead is involved, you can go ahead and pull the trigger and call that a STEMI. The next family are the inferior family, the inferior leads, 2, 3 AVF. And quite obviously, in this particular case, you can see those dramatic ST elevations. Slam dunk, we're activating the cath lab, our work is done. And then you've got the anterior leads, V1 through V4. And you can see in this particular ECG, we've got those ST depressions, dramatic ST depressions that are reflecting the ST elevations in the inferior leads. And so this is actually not just an inferior STEMI, there's posterior involvement in this particular patient as well. So this is a super scary STEMI that we need to act on quickly. What's the one lead that's not highlighted? AVR, poor AVR. AVR is like the orphan of the ECG family. We're going to come back to AVR. Don't feel too bad for AVR. He will get some respect eventually. Now, think about the ballet that happens when you get a STEMI in your emergency department. We are so good at managing STEMIs because we've got protocols, we've got all the key players involved. Everybody knows what to do. The team effort is solid. The ballet has been established. It's lovely. We can get our STEMIs in and out in under 30 minutes from our emergency department. It's that good. Or you have protocols in place to give the TPA, or you have protocols in place to transfer the patient so they can get PCI at another institution. So whatever your protocol is, it's well established, and we do it really, really well. The problem is when it's not a STEMI, but you have these high-risk patients. And unfortunately, we don't have great protocols in place for managing these. And so this is where we're going to need to make multiple phone calls and have multiple conversations with all the key players so that we can turn these high-risk patients into the same positive outcome and management as our STEMI patients. So there are kind of three pathways that you can take with ACS. One is going to be the STEMI, and we know how to manage those, and we're really great at that. And then we've got the non-STEMIs, and those, based on how bad the patient looks and how bad their features are, may go to the cath lab immediately, or they may just kind of get admitted, and we'll do serial troponins, serial ECGs, and the cardiologists manage those in the CCU. And then there's this concept of the solar STEMI, which is not my terminology. This was developed by Mike Abernathy up in Wisconsin. And so what is the solar STEMI? The solar STEMI is not really a STEMI, but it's the ECG, the patient who's acting like a STEMI has high-risk features, and we would treat like a STEMI if it was daylight, if it was regular business hours. So it's a bad EKG and a bad patient who we would want to take to the cath lab if the cath lab was open and the interventionalist was in. But after 5, after 6, whenever the interventionalist leaves, these are the ECGs that we don't activate the cath lab for, but we might want to think about at least having a conversation with the interventionalist. And so let's go through some cases. First, 67-year-old male comes in with pressure-like chest pain. 134/89 blood pressure, 75 heart rate, respiratory rate of 20, and he's satting 96% on room air. I like his vitals. Here's his ECG. So what do we see here? We see a bundle branch block, yeah. So we see a left bundle branch block. So we see that wide QRS complex. We see those dramatic ST elevations in those anterior leads, and we see the posterior depressions in the lateral leads, and it kind of looks like a regular old bundle branch block. Why do I have to worry about a bundle branch block? Well, for some of you who remember, like me, bundle branch block was one of the criteria for activating the cath lab. That was a STEMI equivalent that went immediately to the cath lab. And after some reiterations of the ACC/AHA guidelines, that got wiped away. So when do we need to worry about a bundle branch block? Why would this be a high-risk ECG? Well, with the bundle branch blocks, the ST segments and the QRS complex must follow a rule of appropriate discordance. What does this mean? It means that the QRS complex, if it's predominantly upgoing, the ST segment and the T wave need to be predominantly downgoing. They need to be appropriately discordant. We want them to go in the opposite direction. That's normal. If the QRS complex is predominantly downgoing, then the ST segment and T wave should be predominantly upgoing. Again, they are discordant. They're going in opposite directions. We like that. That's reassuring to us. That's normal. Now, what happens if that doesn't happen? So any concordance, so if you have an QRS complex that's predominantly upgoing and an ST segment that's predominantly upgoing, that's not okay. We don't want them going in the same direction. And if you have a QRS complex that's predominantly downgoing with an ST segment that's predominantly downgoing, again, that's concordant. We don't want them going in the same direction. So that should concern you. The concordant rule is a very easy one to follow, and as soon as you see it, you're going to go ahead and call the cardiologist. That's a high-risk feature. That's not normal. How do we know when there's too much discordance? So how are we going to diagnose a STEMI in the setting of a left bundle branch block? So the Sgarbossa criteria, the original Sgarbossa criteria had a 5 mm designation of ST segment deviation with a left bundle branch block. So if the ST segment was more than 5 mm above the TP segment, then that was pathologic, and you could call that a STEMI. We have now made some modifications to this, and so that was not a particularly sensitive way of diagnosing STEMIs, and so now we have the Smith modification of the Sgarbossa criteria. And how does this work? You basically take the ratio of the ST deviation, so if you look at panel A, the ST deviation is 3 mm. The QRS complex, the height of it is 10 mm. You divide 3 by 10, you get 0.3. Anything over 0.25 is a STEMI. It works the other way as well. So if your QRS complex is predominantly downgoing, the ST segment deviation in panel B is 3.5. The depth of that QRS complex is 10.5. You divide that, you get a ratio of 0.33. That's greater than 0.25. That's pathologic. And so we can go ahead and call that a STEMI as well. And so this is how you're going to diagnose a STEMI in the setting of a left bundle branch block. This is a high-risk ECG that should go to the cath lab. What happened with our particular patient? Well, we measured out the deviation. It was 3.5. The height was 14, and we got a ratio of 0.25. Now, the cutoff is 0.25. In fact, the definition is greater than 0.25, so we were right at the mark there. So I didn't really meet the criteria, but boy, I'm right on the line. And so we called the cardiologist, and we told them, we're like, look, this guy's here, he's having chest pain, he's 67, we're worried, we're calculating out the Smith modification of the Sgarbossa criteria, and we're getting exactly 0.25. What do you want us to do with this guy? And they said, you know what, let's just admit him to the CCU. I totally get it. I understand he's having chest pain. Let's bring him in. Let's keep an eye on him and see what happens. So his troponin came back at 0.66. He did go to the CCU. He continued to have chest pain. And so they eventually decided to go ahead and take him to the cath lab. And what did he end up having? Non-obstructive CAD. And so that 0.25 marker and the fact that it hadn't gone above that kind of worked for this guy. It validated that Smith modification of the Sgarbossa criteria. So anything greater than 0.25 warrants a conversation with your interventionalist and possible cath lab. Here's how I want you to think about a left bundle branch block and how you're going to manage this acutely in the emergency department. If you have a patient with a left bundle and they are unstable, that is ischemia until your interventionalist has proven otherwise. If you have a left bundle branch block and the ST segment and T wave, the QRS complex and the ST segments are concordant, that is ischemia, that is a STEMI, and you need to have a conversation with the interventionalist. And finally, apply the Smith modification of the Sgarbossa criteria. Do the math, and you don't even have to do it yourself. It's on MD Calc. So do that math. If it's greater than 0.25, that is a high-risk ECG, that is a STEMI, you need to talk to the interventionalist about that. Now, that is not a reason to activate the cath lab at 3 o'clock in the morning, but you should wake some people up and have a conversation. That's a high-risk ECG. Second case, so we have a 63-year-old female. She's coming in complaining of exertional pressure-like chest pain. She's short of breath. She has a history of hypertension and tobacco use. She's hypertensive, 167/92. Her heart rate's 90. She's breathing at 20, and she's saturating 93% on room air. These vitals look great. I'm very happy with this. This is very stable. Here's her ECG. And so what do we see here? We see Wellens, yeah, absolutely. So there's Wellens waves here. And so those biphasic T waves that you see in lead V2 and V3, and then that's very symmetric looking T wave inversion in V4, that's abnormal. And those are Wellens waves. Now there are two different types of Wellens waves. There are the biphasic T waves that you see here in V2 and V3. And then type B are the very symmetric T wave inversions that you will see oftentimes in those same leads. Now, in this particular patient, these are type A Wellens waves. And so what's the problem with Wellens waves? This is a proximal LAD lesion. All right? So this is the can't miss lesion, because that is a tremendous amount of myocardium that proximal LAD lesion is going to take out. And it hasn't done it yet, but it's going to. And so this is the time to act, not when the patient is infarcting and the STs are rising. This is when we have a chance to save this patient's myocardium. So Wellens syndrome, type A or type B waves, a history of pain. So they don't even have to have current chest pain. The patient that's in front of you, if they report a history of chest pain and they don't have active chest pain in front of you, that's okay. That's Wellens syndrome. And then a normal or minimally elevated troponin is part of the diagnosis of Wellens syndrome. So do not be reassured by the normal troponin. Do not be reassured by the absence of chest pain. If you see those waves in the correct clinical context, that's a high-risk ECG. 86% positive predictive value of having an LAD lesion. Again, now is the time to act. This is when we can make a difference, before the patient ends up with a huge infarct, goes into VFib or VTAC, and has a cardiac arrest. This is when we can make a difference. So what happened with our patient? That troponin, it's high. It's not terrible. We've seen way higher. Had a 90% proximal LAD lesion, and our interventionalist whisked this patient right up. It happened to be in the middle of a snowstorm, and the interventionalist was stuck in the hospital anyway. They couldn't leave because they hadn't plowed the streets around the hospital yet. So he was stuck. So he's like, whatever, we'll just take her to the cath lab. And he did. Drug-eluting stent placed, patient walked out a couple days later. So this is a great save before badness occurs. Next case. 66-year-old female, pressure like chest pain, complaining of some shortness of breath. She's vomiting in the emergency department. Has a history of hypertension. 155/91, 87, respiratory rate of 20, and satting 98% on room air. Again, pretty good vital signs. I like that. I like them a little hypertensive, gives me a little room to work. But she's diaphoretic. So when the patient is sweating, you should be sweating. Right? Sweat. A sweaty patient is hard to fake. So there is something bad happening. Be aware. Here's the EKG. And the problem with these EKGs are that we see hundreds of these in a day, right? You get stacks of them, and you have to zip through them quickly in between the patients, right? They're coming from triage, they're coming from other physicians, other providers that the tech can't find to hand the EKG to. I mean, these are just nonstop. And so we get EKG fatigue, but these are the ones where we have to actually pay attention. And so what do we see here? We see these diffuse ST depressions everywhere, except AVR. So remember our orphan AVR? Don't feel bad about the orphan. So ST elevation in AVR here, and diffuse ST depressions. So about 10 years ago, some research came out and some case reports came out about isolated ST elevation in AVR. And everybody got super excited because we thought this was pathognomonic for left main coronary obstruction or insufficiency. And so we were activating the cath lab left and right for just isolated ST elevation in AVR. And eventually the interventionists were like, whoa, slow down, hang on. This is a lot of false activations. And so we started actually looking at this a little bit more. So isolated ST elevation in AVR, not an indication to activate the cath lab, all right? ST elevation in AVR with diffuse ST depressions, though, could be one of three things. It's either going to be left main insufficiency, or a proximal LAD lesion, or multivessel disease. Particularly in those diabetic patients, they end up with horrible multivessel disease. So, in the correct clinical context, a patient who comes in with chest pain, has ST elevation in AVR, and diffuse ST depressions could be going down any one of these three paths. Now, other terrible things can cause this pattern, including things like PEs, dissection. So keep those in mind as well. But again, in the right context, this could be really bad ACS, and it could be the first sign that they're about to infarct a large territory. And so what happened with this particular patient? So we got this EKG. The patient looked terrible. We called cardiology. And we said, it's not a STEMI, technically, but boy, it sure looks like they're about to go down that path. And so they ended up taking the patient to the lab. We didn't even have a troponin back yet. 90% LAD and 100% circ. The patient became very unstable on the cath lab table. They ended up having to put in an intra-aortic balloon pump, and then eventually the patient went for a 2-vessel CABG a couple of days later. So in your patients who have that ST elevation in AVR with those ST depressions diffusely, before you pull the trigger and give the patient their dual antiplatelet therapy to send them to the cath lab, you might want to have a conversation with the cardiologist first. Because again, this could be a sign of multivessel disease. And if there isn't going to be something for the interventionalist to stent, then that patient may end up needing to go to CABG. And if you've given them that dual antiplatelet therapy, the CT surgeons may not be so happy with you. So oftentimes what we'll do in cases like this is the patient will go to the lab, and then if it looks like once they've gotten the angio that there is something to stent, they will then go ahead and load in the cath lab with their clopidogrel or ticagrelor. So we don't have to jump the gun and give this in the emergency department, at least have a conversation and talk about the potential that this could be multivessel disease and that the patient may end up going to CABG. 43-year-old male complaining of an achy chest pain, has a history of hyperlipidemia, hypertensive again, 168/70, 84, respiratory rate of 20, standing 94% on room air. All looks good, very stable vital signs. And he's 43, come on. Nobody has an infarct at 43, right? I'm 43. Nobody has an infarct at 43. That's not supposed to happen. Here's the ECG on arrival. Winters, yes. So what do we see here? We see these ST depressions, V2, V3, and then those hyperacute T waves after those depressions. So those big T waves in V3 particularly, with the ST depression preceding it. That's not normal. So ST depressions plus those hyperacute or peaked T waves, this is not hyperkalemia, this is De Winter's T waves. And why do we care about De Winter's T waves? Because De Winter is coming for that LAD, okay? It's gonna knock it out pretty quickly. And so what happened with our patient? 2 hours later in the CCU, look at those ST segments. Boom. So V2, V3, V4. So there's the STEMI, all right? And that happened in-house. So instead of taking the patient directly to the lab based on the De Winter's, Cards opted to watch and see what happens in the CCU. Fortunately, they were able to then activate the lab from the CCU, 100% mid-LAD lesion, and this patient got a stent as well. Okay? So be aware, this is a subset of the hyperacute T waves that we see in ischemia. Hyperacute T waves versus De Winter's. De Winter's has those depressions before the T waves get big like that. And then the last category of high-risk patients that deserve the cath lab. So out-of-hospital cardiac arrest with return of spontaneous circulation. So how do we decide which of these patients go to the cath lab? Because they're not all going to benefit from an intervention. And so this was a set of guidelines that were published by the interventionalist. These are not ACC, AHA guidelines. These are the guidelines that the interventionalist put out saying like, hey, this is what we think. It hasn't been adopted by some major society, but this is what we would like for you to think about before you call us in. And so what are the features that you should think about activating the cath lab for in your post-arrest patient? Sometimes it's easier to think about who you shouldn't do that for. And so in that, patients with multiple unfavorable resuscitation features towards the bottom of the slide. So if it's an unwitnessed arrest, not a good feature for the cath lab. Initial rhythm that's non-VFib or VTAC is also not a great feature. If there was no bystander CPR, not a good feature for an intervention. If it took more than 30 minutes to get return of spontaneous circulation, maybe not so great. If there's ongoing CPR, I mean, imagine trying to stent a lesion or get those wires up into those tiny vessels while there's ongoing CPR. That's pretty challenging. Acidotic patients, high lactate levels, if they're very elderly, so patients over the age of 85, end-stage renal disease, and then also non-cardiac causes of cardiac arrest, obviously. So if it's a traumatic arrest, that patient is not going to benefit from some sort of a cardiac cath or intervention. And so essentially it's going to be the patient who has a witnessed arrest where the initial rhythm is VFib or VTAC, where ROSC was achieved in under 30 minutes, there isn't ongoing CPR happening, and we believe that this is a primary cardiac issue and not a traumatic issue. These are the cases that the interventionalists want to get called on, and they want to take these patients to the cath lab. Now, I would say err on the side of caution. We always give them a call. We say, hey, this guy came in. It's not a trauma. We're not exactly sure what happened, but we got them back. Is this somebody that you might be interested in intervening on? And at least give them the option and give the patient the benefit of maximal therapy. So back to pattern recognition. So the way I think about this when I look at my EKGs, all these EKGs that get put in front of us on every shift, I go through my usual exam of the ECG, and then I go through this mnemonic of how bad is this ECG? How bad is this patient? And so hyperacute T waves, out of hospital cardiac arrest, obviously that's going to be an easy one. Wellens waves, I look for the Wellens waves. Do the math on your bundle branch blocks. ST elevation and AVR with those diffuse ST depressions, and then De Winter's waves. So how bad is the mnemonic I use? It helps me keep track of these subtle ECGs that are high risk and potentially deserve the cath lab. Right. There's my Twitter handle. Feel free to direct message me via Twitter or just shout out to me. And my email if you're feeling shy and don't want to expose yourself on social media. That's it. I can take questions.
Thank you, Tarlin. Let's take 2 questions, and then we're going to move on. Tarlin's giving the second talk, and then we're gonna go on to a lunch break from there. So any questions on that last talk? Nobody.
They're hungry.
Oh, they're starting to get hungry.
Yeah, they're hypoglycemic.
Just a quick question regarding the assessment for this equivalence of STEMI. Do you use the echo at the bedside to add something else, or is useless for you during that assessment?
Yeah, so that's a great question. So do we use echo in terms of trying to help risk stratify these high-risk ECGs? Sometimes, so it really depends. If I'm trying to make a good case, and I do echo on 100% of these patients, but if I see something, if the squeeze looks low, if it looks like there's some wall motion abnormalities, it has to be pretty dramatic for me to pick it up, then I will just use that as I'm talking to the cardiologist or the interventionalist to push my case for the cath lab. If the squeeze looks okay, and I don't see anything obvious, then I know I have a little bit of time. Maybe I'll wait for the troponin, wait for some more data points to come in before I make the call.
Take one more question.
What's your strategy for dealing with cardiologists that read less than you? So I had a circumstance where I had an interventional cardiologist. I said, patient meets Scarborough criteria, and they said, well, I'm not really familiar with the Scarborough criteria.
So your interventionalist was not familiar with the Smith modification or with Scarbosa at all? Oh, dear God.
He said Scarborough as in the fair.
Yikes, okay. Well, Amal has a great tactic where Amal Mattu, where he sort of recommends saying, kind of flipping the script. on your cardiologist and saying things like, as you are aware in the cardiology literature, or as you know from the recent publication by Dr. Wellens. And so that kind of helps lubricate the situation a little bit. And if they don't know, then oftentimes they'll sort of back down and listen to what you're actually saying. I mean, that kudos to the cardiologist for actually admitting that they don't know what the Sgarbossa criteria is. But then that's when you can actually just tell them, like, oh, you know, the ST segments look like they are concordant. It's more than 1 millimeter, and that is, you know, not normal and a high-risk feature of an ECG. This patient would benefit from early cath. It's not technically a STEMI, but I wanted to make sure that you and I had had a conversation that I could document in the chart.
I also think, sorry, I'm not trying to answer your question for
No,
you,
no.
but I think this is part of one of the missions of this conference is that patient care starts pre-hospital and goes through to the end of the hospital when they go to the ICU and once they get discharged. And I think these are important conversations that there may be things maybe in the cardiology literature that emergency docs don't know about or vice versa. And this is where you sit down and you talk with your consultants professionally and you have discussions about trying to make system changes. But you know, calling people out and name bashing, that sort of thing is not going to make a difference. But there's plenty of things I've learned from my consultants that I didn't realize was in their literature. So that's just another way to handle
And
that.
remember, these are all high-risk ECGs. These are not determinants of cath lab activation. And so again, this is a decision that you're going to come to with your consultant. And if they opt not to activate the cath lab, and that's okay. Again, none of these are slam dunk STEMIs. These are just really dangerous to ECGs that we want to make sure we're cognizant of and that we don't discharge home. But again, you don't need to get into a fight with the cardiologist, and we're certainly not going to activate an entire team. So remember, the team is not just the cardiologist, but you've got techs, you've got nursing. There's a whole bunch of people that need to come in for this patient. And so, you know, if the interventional is saying, look, this can wait till tomorrow, or, you know, let's admit to the CCU and trend, that's okay too. Again, we can't mobilize all these people for something that's not necessarily a STEMI. Is there another question?
Yeah.
Yeah.
I'm actually going to pick on Dr. Landon Welford and get, he's a cardiologist and he's here. And really, it's the same question the gentleman next to you asked, Landon. What do you think, well, I don't know. There's certainly some percentage of emergency medicine docs that are clueless about this presentation today. Do you think most community emergency medicine or cardiologists, if I called you up at 2 in the morning and said, I got this patient with Wellens syndrome, are going to be aware of that and know that it's the implications of those EKG findings that we talked about here?
Great lecture, by the way.
Oh, thank you.
I think they're aware of everything but the Scarborough Fair criteria. I'm going to write that down. I think that is news to most. Wellens is very well described. It's been out there forever. The older guys, myself included, still react to left bundles, especially if they're new. But I would say the Scarborough Fair criteria are new to most cardiologists out there in the community practice.
Thank you.